Thanks for joining us here in sunny Moses Lake. It's dry for some, but for some of us it's a little cooler. So thanks for coming, and for those who are joining us on the phone. We're a little bit different setup, and my sidekick Caroline is calling in today. So the chat, make it public or chat to Caroline because she will be monitoring the chat. She doesn't know that yet, so she may.
I do now.
She does. Thanks, Caroline. So let's start with introductions. I'm Wendy Brezzi. I'm the Whole Person Care Collaborative Manager.
And I'm Linda Evans-Barlett with a mouthful of sandwich. And I'm the Executive Director of North Central ACH.
Ellen Knight from Health Centers. Holly Zvonek, Children's Home Society.
Michael Lopez, Grant Integrated Services.
Gail Goodwin, Grant Integrated Services. Deb Miller, Action Health Partners.
Craig Lockoff, Woods Health.
Heather Messer, Moses Lake Community Center.
Alan Noble, Moses Lake Community Health.
Sheila Shilson, Moses Lake Community Health.
Jamie Hilliard, Catholic Charities. Christina Basin Family Medicine.
Jorge Rivera, Molina Health.
Mariah Brown, North Central ACH.
Heather Smith, North Central ACH. Tammy Gleason, North Central
Action Partners.
Nick Frost, Parking Medical Group.
And Teresa's in the back corner taking our minutes. And how about on the phone? Who do we have on the phone?
Good morning, it's Caroline from the North Central ACH in Portland, Oregon.
Karen Jacobson from Family Health Centers.
Lisa Apple with Okanagan Behavioral Health Care.
Rebecca Voigt with CSI.
Rachel Petcher with PSF.
Land Community Hospital.
Paul Hadley, the Center for Alcohol and Drug
Valley Clinic.
Paul and Tracy, I believe.
Did you get me? Paul Hadley from the
Stacy
Center.
Miller, Mid Valley Clinic and Hospital.
Anyone else?
Amelia Davis with Coordinated Care.
Gwen Cox from Comagine Health.
Blake Edwards, Columbia Valley Community Health.
Kathy Rhymes from CSI.
Dr. Wallace from Family Health Centers is also online. He's told me earlier he'd be muted. Anyone else? Okay. So you have the agenda and minutes in front of you. I hope you brought your magnifying glass, because this is what happens when you print from home to a computer at work, to a printer at work. You get 2 per page, so not sure exactly how I did that, but you do have the all this information on your email, so for future reference if you need it. If you're able to read the minutes, the first set is the April minutes, and I'll need a motion to approve those because I failed to bring them at our last meeting.
We make a motion to approve both sets.
Hey, Sheila, second? Oh, to both sets?
Yes.
April and May approval.
Make a motion to approve both.
Second to approve both sets of minutes?
So seconded.
That was Paul.
Yes.
All in favor?
Aye.
Aye.
All opposed? Motion passes. So we have announcements. I'll start. Are there any updates or announcements from partners that they would like to share? Chris had one from Catholic Charities, but I don't remember off the top of my head.
I have 2.
Go for it.
So the first one is that True Blood
has awarded extended funding for our True North program in Wenatchee. So for 18 months it's funded. They're looking to expand services in Okanagan County and other opportunities that are out there. So it's a big deal for them. Another one is that we're partnering with Pacific Northwest University for an opioid conference summit that is in June. I'll leave the minutes and itinerary on the back table. It's a 2-day event that appears to be pretty great, actually. So,
I'm having a very hard time hearing.
I was concerned if people were able to hear us on the phone.
So we'll just have to speak up and project. Can you hear me, Paul?
Yes, I can hear you perfectly.
So just if you project it, it'll pick up a little easier. Anyone else have any announcements? One thing I had that didn't make the slide deck was we were able to get the numbers from Healthcare Authority, and as you know, the payments to the WPCC learning community, quarterly payments are based off claims and beneficiaries, and so we finally got those numbers and sorted it all out, and it looks like we should be good to go to pay everyone. The portal's closed right now, and I think it's June 28th that payments go out, or they should receive repayments.
They will receive payments on June 28th.
All right, so June 28th, you should be receiving your payments. So we're still within our MOU of 60 days after the submission of reports, but just wanted to give you an update on that. We did set the date for the annual meeting. We are tying it in with our learning activities. We're trying to use the time that you've already committed to with a kickoff of continued population health. We will have moved through all the basics or foundations of the empanelment, the team-based care, and more onto population health management, really combining everything together. So I am working with CSI and CCMI and really planning a really good conference. So October 4th at the CTC. Just a heads up, more details to come. There will be a storyboard also that will be asked of each of you. And more information on that one to come. Quarterly reporting. This is due the last day of the quarter, which for this one is June 30th. Just as a reminder, if you go into the WPCC measures and click on that, you can enter measure data and update your progress to date. There are 2 reports. Last quarter, there was some mix-ups. Some individuals forgot either all of it or forgot one or the other. So just kind of a friendly reminder. There's the quantitative, which is the measures, the numbers you're putting in, and then the qualitative, which is where you're putting your change status, whether you started something and where you're at within the implementation, as well as the successes and barriers, that narrative section for each section. There are 8 sections. I also wanted to tell you that we are doing a measurement cleanup, and many of you know this. There were 530 measurements total, and some of those were duplicates. 39 recommended measures were chosen by multiple organizations, and there were 302 optional measures. What that means is there were 302 measures chosen by individual organizations, and they are not like anyone else. Therefore, they have to be defined with a numerator and a denominator. So the first bucket, there were good measures, they're relevant to your aim statement, and the numerators and denominators are defined. Most of those are in the portal. Some of those, Mariah and Heather have been working with the organizations to get those defined, but we have to do batch uploads. We can't just send them just small bits of information, but we're working on that. The second bucket is there are good measures. They're relevant to the aim, but the numerators and denominators have not been defined yet, either because Mariah and Heather haven't gotten to you yet, or you're working with Heather and Mariah right now to get those defined. It may be that your organization has already defined them because you're pulling the data from the EHR. You just haven't gotten that information to Mariah and Heather yet, and they will be working with you on that. The next bucket is they're good measures, but they're not relevant to your aim, and the numerators and denominators are not defined. we can weed those out. No point in defining them if they're not relevant to your aim statement and what you're trying to achieve. And the fourth bucket is they're not a good measure, they're not relevant to your aim, and they're not defined. We can weed those out. So let me show you where we're at. These are all the organizations, the total measure each organization has, how many are defined for each organization, and how many are not defined. So if you have a lot of them that are not defined, you may want to be taking a look to see how relevant they are to your aim statement and if they're worth defining at the moment. If they're already defined, you just need to get that information to us. And again, Heather and Mariah can work with you on that.
Nice job, Grizz in Mid-Valley.
I will say that, again, we are only allowed to send, for our contract with CSI, to the portal one batch a year of updates on measure. So we're trying to get as many as we can. Those that are defined by the organizations already, that means you're already pulling that information from your EHR, that will be the batch that we will work on and be sending up fairly soon. Then Heather or Mariah will work with you on those that are not defined. You haven't been measuring it because you're still trying to figure out how to get the data. Those we will spend the rest of the year getting those defined and trying to decide, is it something you really want to track? And that will not be sent up to CSI until December or early January. Because like I said, we're really supposed to only do this once a year. Otherwise they charge us more. So those who have already defined and expect to see it in the portal at the end of June, you will not, because we have not sent that information up to CSI yet. Any questions? Comments?
Can you hear me?
Yes, I can.
Can you really tell me, this is Dave Colty, when you say not defined, everything that I'm measuring or sending you, I know what it means. I know what it's defined as. So I don't understand when you say it's not defined.
Craig, Dr. Coley, I talked to Craig about this, and I will get with you afterwards. It's my note to myself on that number. You're
okay.
Good.
Thanks.
Anyone else?
So just so I'm understanding, this is currently there's 21 not defined for Catholic Charities, or is that just what's based on the portal, or?
So if you've been working with Heather to define some of those, then that's not in this number. This is what I had. So it hasn't been updated. So some have been working with Heather and Mariah on getting their information updated. You're welcome. Anyone else? Feel free to reach out if you have any questions or want to continue the conversation.
Can I ask one question? You said you can only update them once a year. I think we were under the impression we could update them quarterly. Can you just go over that one more time?
You will be entering your data quarterly, but you will not be adding or deleting actual measurements quarterly.
When is the time when we can change those? So this is Dr. Guffey from Lake Chelan. We've had some pretty major staff changes, and we have to sort of reevaluate all of our measures and what someone who previously was working for us had selected without consulting other people, and we're sort of trying to figure out what's going to work for us going forward, and so I'm wondering, when is the time we're allowed to make those changes?
So right now is a good time. If there's new measures that you want to choose now and they're already defined, now would be the time to put them in. If you're thinking you want to measure something, you just don't know how to measure it, we have the next 6 months to figure out how you're going to measure it, and that update will go in then at the end of the year. And I believe we're meeting with your staff in a week or two, and we'll be happy to talk to you more about it at that time.
Okay, perfect.
Anyone else? Okay. Just wanted to remind you that there's a, for the WPCC learning community, there's a calendar on the portal. I'm trying to get all the work group and CHI meetings on there in case you're interested. For your reference, it's in your packet. You'll have it on your email. Here are the contact information for the opioid work group, the TCDI work group, and the CHIs, if you're interested in those meetings. We've been talking about them at our WPCC, so you can kind of see where the WPCC overlaps with the work groups as well as the CHI. For the dates that I do know, they're up there. Chelan Douglas, I just saw that and it didn't get on here. Kelsey, help me out. Your next Chelan Douglas? June 12th.
3 to 4:30 at Confluence Technology Center.
3 to 4:30 at Confluence Technology Center. But there are those emails, so you can contact them for, if you want to get on their listserv. We do not manage that, and so if there's a call-in option, though individuals listed here are the ones who manage that call-in option. So if you want to just get them, just see their minutes and that, feel free to give them an email and let them know you want to be added to the list. I just want to run through this really quickly. If you're not familiar with the community health worker, it's been talked about a lot in different venues. There is a community health worker training. It's a free 8-week training. It's a hybrid where you meet twice, and then there's an online portion of it. The third quarter and fourth quarter, those are the locations, the dates and locations, and the times for those. And you do learn, or the individuals who participate are anywhere from clinic directors to current community health workers that aren't necessarily trained by the state, patient advocates, patient navigators, volunteers. So if you have anyone in your organization that wants to be trained as a community health worker, you can take a look at this. There's also different tracks that you can go by, and I don't think I put it in here, but there's, once you got the basic community health worker training completed, then you can go on and do a diabetes one or obesity, or there's just different tracks that they offer each quarter. And I failed to put that link on the website. I will get the link to that to you. It's from the Department of Health. So if you Google Department of Health, Washington State Department of Health Community Health Worker, you would be able to find all their information. Learning activities, just a quick update. There's an MI Train the Trainer coming up. We have about 13 or 14 participants. And that's June 10th through the 13th at the CTC. There's also the team-based care. Thanks for everyone who's signed up. I understand some organizations have chosen not to participate, and that's okay. But if you have chosen to participate, it starts this week, June 5th. It is a webinar. It's the virtual. The call-in information is on the portal if you do not have that already. All your team members need to register. They don't all have to attend the live webinar, but they do need to register because that's how we get their email addresses and the information is sent out. Also, after they register, there's an assessment portion that, an assessment for the team that they will need to complete. And if you haven't done that yet, please do that ASAP. The faculty are waiting for all those assessments to come in because they will be providing individual, having individual conversations with each team based on those assessments. And finally, we need to identify a team lead. I have not done that for each team, so if possible, we need to do that. Just let me know who you want your lead to be for your team. And then I'm going to turn it over to Caroline. She has a pre-manage update.
Can you hear me?
Sure can.
Great. And Wendy, while I talk, I just wanted to point out that for those of us on the phone, there's this weird like blue pencil mark across all the slides. I think it's one of those drawing tools. I'll let you figure that out. So real quick, everyone, I wanted to give you an update. We'd intended on offering a 3-part webinar series on pre-manage for 3 separate cohorts of WPCC work, so like 5 to 6 organizations at a time. CMT has been going through some growing pains, including staffing changes, and it's kind of set our timeline back. So here's where things stand now that we've adapted to these curveballs. Rather than do 3 cohorts, we're going to open up the webinars to any WPCC org that is ready to move forward or ready to learn more. And rather than offering 3 live webinars, we're going to ask people to watch a self-paced pre-recorded webinar and then just do 2 live webinars to really dig into questions that organizations have. So we will send that out as soon as we finalize it with the CMT team. And I also wanted to clarify that you don't need to wait for NCECH or these webinars to move forward with adopting pre-manage. Some of you are already well underway. And if you want to get started with CMT, there's a discovery form to fill out that you would return directly to them. And I've posted it to the portal, and I'll also put the direct link in the chat box of the Zoom meeting. So stay tuned for more info, but that's just a quick update of where things stand. Any questions?
Any questions about pre-manage or any of the learning activities I talked about? Okay. Here we go. So a few weeks back, I received this document called Sharing Substance Use Disorder Information. It is a guide on the federal regulations of regarding the CFR 42 and privacy. This guide was sent out to have some clarification as well as some provider and patient resources. We also had a call with Healthcare Authority, and Amber Sexton and Matt Keene presented and found it to be very good. So I've invited Matt to come and give a presentation on that today. So Matt is the privacy officer for the Washington State Healthcare Authority. His office is responsible for the agency on compliance with healthcare privacy laws, and he works across the agency to help with outreach and implementation of a wide range of healthcare authority programs and initiatives. And before joining Healthcare Authority, he was an assistant attorney general advising the Healthcare Authority and DSHS on privacy issues and other aspects of the state's Medicaid program. And before he talks, he wanted to share a video, and I will play that now. I gotta share the right screen though. One moment. Still not sharing the right screen. One thing about Zoom. Here we go. I believe the audio will come to from my computer. We couldn't get it from the OWL.
Hi, my name is Sharisa Patinos. I'm the Deputy Chief Medical Officer for the Washington State Healthcare Authority. I'm a family medicine and addiction medicine physician, and I've helped to sponsor this toolkit. 20 years ago, most people thought addiction to drugs or alcohol was a choice, a weakness of character. This thinking led to discrimination and a law enforcement-focused approach to treatment. In order to protect people from discrimination, strict federal privacy was put in place. While well-intended, the rules are complicated and hard to understand. This has led to barriers in sharing important information across different disciplines of care. The very good news is that today there are effective medical treatments for opioid use disorder. There are also behavioral therapies that can help people with other substance use disorders. This toolkit is meant to help medical, mental health, chemical dependency professionals, and patients understand how a person's information can be safely shared and protected. In order to better manage the whole health of a person, which includes their mental health, their substance use disorder history, and their physical health, better sharing of information needs to occur across healthcare disciplines. Substance use disorders are medical conditions that are treatable. Perhaps when healthcare providers become better at asking about substance use and sharing this information with other health-related disciplines, there will be less shame and trying to keep hidden treatable conditions.
So Matt, I will let you share your screen. You have the floor.
Okay, can you see my screen?
We can.
All right, excellent. Well, thank you for the introduction and thanks for having me. I always like to start out with that video from Dr. Patinos to set the stage a little bit and be able to speak from our personal experience. I want to quickly go through an agenda here and then we will dive in. So briefly, I want to talk a little bit about the issues with implementing 42 CFR Part 2, those privacy that govern SUD information, and then talk
Matt, we lost you.
About the healthcare authority's next steps. A couple of caveats before I get started. The first is that I normally give this presentation with Amber Sexton, who is our data governance manager and wasn't able to join us today, so please bear with me a little bit. And the second one is that this is really intended to
I think it's our internet, even though I thought it would be stable. Matt, can you hear us?
So with that in mind, I am just going to give an overview, but I'm open to any questions if anybody wants to dive deeper on any of these topics. So the first thing I want to talk about is just the basic reason why 42 CFR Part 2 is an issue for care coordination specifically. And that is that under HIPAA and under our general state privacy, that seamless integration between providers for all the care that the person's receiving. But there's a fundamental SUD information. Not only are there not exceptions to share information for things like payment, kind of administrative functions, you also can't share that information even and if that facility had an SUD facility as part of it, even within the same building, those providers won't be able to talk to each other without consent, which can create barriers to integrated care and prevent those providers from really understanding the whole range. One of the reasons that this law is particularly kind of complicated and difficult to implement is that it was also developed on, or when I say it, I mean Part 2 was developed on a completely different than other healthcare privacy laws. So when we think about HIPAA as being kind of the normal baseline for privacy laws and what everyone's
Not hear us at all.
Contrast Part 2 was originally created in 1972, and until recently, it hadn't been updated since 1987, which is also the year.
I think it's our internet.
Your phone? It's on speakerphone?
Tell him that we can't hear him.
Matt, can you hear me?
I can.
I think our internet I think it's our stability. Is anyone else on the phone having a hard time with it cutting in and out, or is it just us in the room?
Wendy, the phone seems to be very clear on my end.
I talked to audio guy here. You can continue.
Wendy, this is Rebecca, and I can hear fine.
Thank you.
Okay. People who have been following this closely would know that there have been changes recently, and it's been a pretty hot topic at the federal level. In 2017, there were some updates to the rule for
Texting with the audio guy.
but fundamentally, the basic rules and the basic challenges that the law has created were not addressed. It continues to be discussed, Last year, there was legislation that passed through the House almost unanimously to change Part 2, or the legislation that underlies Part 2. Then that's been reintroduced again this year, and we'll see what happens. The other thing that's happening is that SAMHSA has been considering further rulemaking. You'll notice that on it's already out of date. It says that there was supposed rulemaking proposed in March of 2019, which is come and gone without a rule. But especially if were the biggest gaps at the state level, and that's what you see on the right here. And the first one was really the people, that there's just an inconsistent understanding of Part 2 that's affecting people's care. There's also a lack of policies and processes at the state level to help alleviate that inconsistent understanding. And then the third one is that from a technology perspective, even if we had perfect understanding and consistent understanding across the state, there really aren't health information technology tools in place that will allow it to be implemented effectively. So at this point, in this particular toolkit is really aimed at to come out that will be in a better place to implement them effectively. So just a little bit about this process that we've been working on for a little bit over a year now. We didn't want this to be just a healthcare authority effort, particularly keeping in mind that we wanted this to be something that could establish a common understanding and not just HCA's understanding. So we convened first a work group of state agencies that touch healthcare. So we had the Department of Health, Department of Labor and Industries, OFM was here, the new Department of Children, Youth and Families, OSPI, any agency that had some type of health program within it helped collaborate to think about what would help people in the community understand the law and what the common issues were. Once we had a draft of that, we widely circulated it with community partners. Again, keeping in mind that a product that doesn't help people understand the law or that isn't accessible wasn't going to do much good. So during that phase, we tried to select a variety of providers of different sizes, of payers, community partners like ACHs, and that was also a very helpful process. And then just in the last month or so, the document was finalized and published. So I think I've gone over this for the most part. The idea is, again, that we wanted these materials to be created in a way that could speak to how people deal with information in reality. So in addition to kind of the basic legal guidance, we also wanted to create tools that could actually be used or could help illustrate the issues. So one of those is things like real world scenarios, like walking through how this information may need to be shared in reality. A sample consent script for providers to use who are not comfortable asking for this specific type of consent. An informational brochure was another one, and then a Part 2 compliant consent form that implements recent changes to the law. So what I'd like to do next is just walk through some of the basic sections of the guidance. And then after that, I think I'll give you all an opportunity to ask any questions you may have. So one of the common questions that comes up about part 2 is who is subject to it and what information is subject to it. So we have a whole section of the guidance that is aimed at walking through the process to determine if you're subject to 42 CFR Part 2. And what you're seeing now is a decision tree that's kind of the culminating piece of that section. But in addition to this, it also goes into some more detail about some of the stickier issues that we encounter. So one example would be a primary care physician who provides MAT, and whether the fact that they're providing that medication-assisted treatment makes them subject to Part 2. Another one is what happens when there are co-located services and you're treating somebody with co-occurring disorders, and is all the information subject to Part 2 or only some of it, and how would you go about drawing those lines between the two. So that kind of background information, again, focusing on some of the most frequent questions that we were receiving. Another section that I already talked a little bit about were the real world scenarios. So for this section, we tried to imagine a person who has a substance use disorder and is receiving services from a wide range of people. That could include their physical health providers, it could include an ER provider, inpatient or outpatient SUD providers, and trying to then use that basic diagram to explain how these different people who are involved in the person's care could exchange information with each other. And through that, we also wanted to highlight that there are also at least a few examples where information can be shared without consent, and make sure that people understand that those exceptions do exist. So here is one of the actual scenarios, and this is one of the scenarios where information can be shared without explicit consent, which is when there's a legitimate emergency and it's not possible to obtain the consent. And you see that we have the general description of the scenario, what the flow may look like from the time the person arrives at the provider and how they would exchange that information. And then an explanation of what the rules are under Part 2, and also what the rules are under HIPAA and our state healthcare privacy laws and how those may interact. Because there are some circumstances where HIPAA or state law are actually more stringent than 42 CFR Part 2, and you need to make sure you're following all of them. Another section that we included was the requirements for a 42 CFR Part 2 compliant consent form. And we thought that this was a really important area to focus on. This is not a form that we are requiring anybody to use, and it's honestly not even a form that I necessarily expect people to implement in its current form, or to print it directly as it is and begin using it, although you certainly could. But what we really wanted to do is show how some of the recent changes to Part 2 could be implemented, because going along with that idea that there was an inconsistent understanding in the state about how this law works, I think that there's an even more inconsistent understanding about those recent changes in 2017 and 2018. So I think the biggest example of that is that you are now allowed to gather a consent form that allows information to be shared with all treating providers for care coordination purposes. So before, you used to have to specifically list every person that the information could be shared with, which obviously could be extremely burdensome or impossible, especially if at the time when a provider is asking for consent, that person doesn't know who their providers are going to be in the future. I will offer one caveat, though, that although this change exists, it's not particularly easy to implement. There are some difficult administrative pieces that come along with it, but we still wanted to show that it can be done. So this is just a basic overview of the different parts of the consent form. And I want to skip to, section 2 reflects one of the changes in the law, which is that you are also now allowed to have a single consent form that allows information to be shared by all providers. So all the SUD providers who have information about a person can rely on this same consent form. So again, before the requirement was that each provider who was sharing information was specifically listed on the form. And then section 3 talks about the change I was mentioning just a minute ago, which is that you can now have a single form to allow treating providers or all treating providers to receive information. And here we wanted to make sure that we incorporated this change in a way where it could be implemented, but also to continue to respect the person's right to choose who their information was shared with. So a person could select that they wanted to share with all treating providers, or they could still do what has historically been done and choose to only share with people that they specifically identified and listed. And the hope is that this type of form and selecting options like this will make it easier in the future as we move forward with technological solutions to implement actually managing the consent. Another section that was added with the help of Dr. Fatinos was a provider script. So we know that one of the barriers to allowing the sharing of this SUD information is that it creates a burden on the clinical process for that provider who's gathering the consent. And there are some providers, obviously, who are very comfortable asking for a consent and receiving it, and others who are not. So this was really an idea of just setting out a template that people could use and adapt if necessary to work into their own clinical workflow. And the last thing that I wanted to touch on here is a brochure that's intended to be used, or I should say, to be available for the person who's receiving the services. I think we're probably all accustomed to seeing an explanation of privacy practices that are really covering HIPAA. You'll see them in the waiting room when you go into a provider. They're widely available online, but there's not very much out there that really talks about Part 2. So we wanted to have again a more accessible explanation of what this law actually means and how a person gets to control how their information is shared and who it's shared with, and really to present it in a way that makes sense for the person, and as opposed to just being kind of legalese to protect the provider who's gathering the consent. So those are the basics of what I wanted to cover. Again, this is just an overview. The website is live now on hca.wa.gov. If you even just Google HCA consent management, you'll get taken to the page. But I did want to provide an opportunity if anybody had any questions.
Yeah, I have a question. So if I understood you right, you're saying if in a primary care, I guess you call it a physical medicine provider clinic, if they're providing MAP therapy, they don't need to obtain specific consent to disclose substance use treatment. Is that what you're saying?
That's right in most circumstances, yes. As long as it's not kind of their primary role and they're not holding themselves out as an SUD provider, that's correct. And the document does walk through that logic and the questions you would want to ask yourself to make sure that you're compliant.
Any other questions?
So
do these rules pertain just to licensed or certified behavioral health or substance use disorder providers who do put themselves out there as that kind of provider? And maybe I'm asking the same question. Does it just apply for those who are licensed or certified by the state as a substance use disorder or a behavioral provider?
So the law actually doesn't tie into state licensing or certification requirements. The way it operates is that the test is basically whether the provider holds itself out as providing SUD services. And again, it's kind of a vague term, and there is a little bit more explanation of exactly what that means in the document and whether they receive federal assistance. But again, the definition of federal assistance is also very broad and would include kind of almost any type of grant funding or even receiving Medicaid payments. So trying to think of another way to answer the question. It does not apply to, for example, a primary care physician who has somebody come into their office and self-discloses that they have a substance use disorder, and that gets documented in that provider's clinical records. That is not the kind of thing that Part 2 is intended to apply to, if that helps.
Anyone on the phone have any questions?
I have one more question. So as a substance use disorder provider, one of the issues that we see with this universal consent is when someone wants to revoke the consent from an individual provider. So is there any work going on around that?
Yes, so I think that gets into that technology piece, that although we can create the form now to be effectively implemented, you really have to have some type of technology that can implement the consent in a scalable way. So that means you need to have a system that can include all the information about that consent. When does it start? Who can information be shared with? And then also, where does that person go to revoke consent so that it gets kind of uploaded into that consent management system? So work is ongoing around that, but I don't have a specific update on when there'll be more detail about it.
Thank you.
Anyone else? If you're online, Caroline put the link to the website in the chat box. For those of you in the room, on your agenda, you'll see a bit.ly link on that section that will take you to the website with more information. There's some informational videos there. There's also the guidance document there that you can take a look at. It's a fairly lengthy document with several different scenarios that may help you. Anything else from those in the room or on the phone? Other questions? Hearing none, thank you, Matt. We appreciate it.
All right, thank you all. Have a good day.
So this now leads us back to get my screen share back up.
If I could, Wendy?
Yes, you may.
I know that Senator Patty Murray's office has been very involved in trying to get the changes according to CFR. So if you have thoughts or comments that you're willing to share with the senator, she has been looking for additional information because it did get stuck in the Senate last year.
All right, and with that, I'm going to turn it over to Alan Noble, who's going to share Moses Lake Community Health's project for quality improvement that they've been doing on their SBIRT project. Do you want me to advance the slides, or do you want to come advance them here?
I'll do the slides.
Go for it.
All right, well, thanks for the opportunity to share with you. As Wendy came to our site and asked what sort of things we're looking for from the Whole Person Care Collaborative, I had mentioned that I like to hear what other people are doing, and I like to hear specifics. Operationally, how did they solve that problem? What problems did they encounter as they tried to tackle this or that issue? And so by speaking up, I volunteered myself. And so I wanted to share today what we're doing at Moses Lake Community Health Center in our process of implementing SBIRT in our organization. And so before I begin, so if you represent a healthcare center, could you raise your hand? Okay. If and then keep your hands up and put them down. If you keep your hands up if you are still, yeah, I think you need some exercise over there. So keep your hands up if you are implementing, if you have SBIRT implemented in your site so that everybody that comes into your organization is being screened, all your patients. You guys are doing it there? So some are, some aren't. That's just what I wanted to see is kind of where we're at. Unhealthy alcohol and other drug use is the most common cause of preventable death in the United States. And despite their frequent presentation in primary care, unhealthy alcohol and other drug use often go unrecognized and not addressed in a busy healthcare center. So in November 2018, so not too long ago, the USPSTF related their recommendations, and they essentially recommended screening in primary care settings, all adults 18 and over, including pregnant women, for risky or hazardous drinking, and offering brief behavioral counseling interventions to reduce unhealthy alcohol use. And so at Moses Lake and Quincy Community Health Center, we have 25 medical providers. We have 2 medical sites, and we have currently 3 co-located and integrated behavioral health consultants. We see just under 30,000 unique patients per year, and we have well-established workflows for screening all of our patients for depression, for tobacco use, passive smoke exposure, colorectal cancer screening, breast cancer screening, cervical cancer screening, and so forth. But we did not have a standardized method for alcohol or other drug use screening at our health center. And so we decided to embark on this process of implementing screening. And so SBIRT, if you're not familiar with that, I'm sure a lot of people here have heard that, it's an evidence-based approach to identify patients who use alcohol or other drugs at risky levels with the goal of reducing health complications, diseases, and accidents. So it stands for, S stands for screening, using a standardized screening tool to screen patients. BI stands for brief intervention, which could represent just a short conversation, for example, using motivational interviewing techniques to help reduce harm. And then the RT stands for referral to treatment for folks who need extra help. This slide here comes from a collaborative out of Colorado, and I use it to help train our staff. What we're really looking for is not the big blue box, the people at low risk for alcohol or other substance use, but those that have risky behaviors. They're the ones that we're trying to filter through and identify and offer brief interventions. And then on the top, the 4% are folks that might need additional treatment. And so this is what we started to do, and this is what I want to share. And we started off by identifying our values. We wanted something that was simple. We wanted something that wouldn't put a big kink into operations, because we wanted to screen all of our patients. And as you saw, it's 30,000, close to 30,000 a year. We wanted something that's evidence-based. So whenever I ask medical providers to do something, I want to make sure there's some good evidence behind it. And it's meaning that it would have to be a sensitive and specific screening tool. We wanted the ability to standardize across our entire organization and all care teams. So any MA covering for any medical provider would know how to do this workflow, and it would take place every time. We wanted to be able to utilize the expertise of our integrated behavioral health consultants. And as I stated earlier, I wanted it to fit naturally within existing workflows, something they're already used to doing. Not another sheet of paper to say, can you remember to do this each and every time? We find that doesn't work so well. We wanted to follow along with the spirit of motivational interviewing, and we wanted to make it easy to document that it had taken place. So again, simple, easy, reproducible, standardizable. And so we reviewed through various pieces of literature. Here are some of the items that the references that we utilized. And I started filtering through various alcohol screening options. There's lots that are out there. On the left, there's the audit. It's a very common questionnaire. It has 10 questions, takes about 10 minutes, and it has a 90% sensitivity and 80% specificity. There's the Audit C, and so it's a shorter version of the audit. It has 3 questions. The sensitivity drops to 73% and 91% specificity for women. And then you can see the sensitivity and specificity for men. There's a CAGE questionnaire, has 4 questions. Its sensitivity is pretty low, and as well as the specificity is really to establish more of a substance use disorder. And so it didn't really fit our desire to identify folks maybe beneath the criteria for a substance use disorder, but show risky behaviors and could benefit from a brief intervention. And so down at the bottom, we came across a single item question that showed that asks, how many times in the past year have you had 5 or 4 for women, more or more drinks in a day? That single item question has 82% sensitivity and 79% specificity for identifying unhealthy alcohol use. And so it had a decent validity with that single item question. We went through a similar option with screenings for drug use. There are various out there. The DAST has 10 questions, takes about 10 minutes, very high sensitivity, obviously. And there's a SODU screening test, has 2 questions, has decent sensitivity and specificity. There's an ASSIST, you'll see that up on the right. It's big, very involved, has up to 80 questions depending on responses. Again, there's a single item question that asks how many times in the past year have you used an illegal drug, marijuana, or used a prescription medication for non-medical reasons. That one in one study had 100% sensitivity and 74% specificity. We also reviewed through, most of those studies were done for adults. We also looked at various options for adolescents and came across the CRAFT questionnaire. It stands for C, have you driven in a car with somebody who is high or using? Have you had to use alcohol or other substances to relax? Have you used when you were alone? It's the A. The F, have you forgotten things you did while using? And then family and friends, have they talked to you about cutting back on your use? And have you had troubles getting into trouble while you were using drug or alcohol? And this questionnaire has stages to it. So if they test out negative, it's quick, it's simple. If they test positive in a couple of the initial questions, there are a couple follow-up questions. And that one goes along with the 92% sensitivity and 64% specificity. I really like this because it has to be different than the adult question. If you're asking a 15-year-old how many times they've drank 5 alcohol beverages, you've already kind of missed the boat for unhealthy alcohol use. And so we selected a screening tool. So we went with the single item question to start off with for the alcohol and drugs. It's simple, standardized, evidence-based, sensitive and specific, and then we would have follow-up questions if they tested positive on the single item screener. And those follow-up questions would then help us be able to document DSM criteria if we were looking to establish a substance use disorder or lack thereof. And so we built the screening tools into our standard workflows for all care teams. So as it currently stands, every MA, when they room a patient, we use a custom intake form, something that we built for our process. It looks like this. And so the MA is already using this. There's questions they ask about the chief complaint. Have they been to a hospital since their last visit? What language are we using this visit? Smoking status, passive smoke exposure. And the area in the brown box is where we added the substance use screening. And so you'll see, it might be difficult to see there, but they're the 2 single item screening questions are there. And so if they answer and then below that, there's our depression screening, colonoscopies, people called other health maintenance items continue on that form. So it just fits right in with what they're doing every patient, every time. And so if the patient answers 0 to each of the items, screening is completed. If they answer positive to one of the single item questionnaires, it prompts the MA to ask additional questions. And we call it reflexing. It reflexes then to the audit questionnaire for a positive alcohol single item screener, and to the DAST for a positive drug single item question. And so one thing we found as we started to do this is many patients became uncomfortable as the MA was asking questions about alcohol use. These are some people's secrets and things that are hard to share and they haven't talked to people about perhaps. And so we implemented, again, following the spirit of motivational interviewing, a question to ask permission. And so we standardized it right in there so the MA has to ask first before proceeding with the additional questions. And we found that really helped to reduce some of the anxiety. It doesn't get rid of all of it. I think we're still establishing a new norm that this is part of your primary health care. So some people still express some worries. Are you going to report this to my employer? Is this going to immigration? Who will know about this? That sort of thing. Those questions still do come up. And so by asking permission, the patient acceptance went up dramatically, and the MAs felt a lot more comfortable asking. And so if they answer no, then once asked permission, then the screening is completed. If they answer yes, there's a red prompt to ask the MA to document the audit or the DAST. This is what it looks like in our electronic medical record. You'll see up on the top right, there's 2 blue buttons. The MA can print out a paper form. We wanted to give options. Some medical teams, they found it more comfortable to give a paper form to the patient to complete in the anonymity or relative anonymity of the room, and then give to the medical provider later, which then can be put in the medical record, versus answering the questions directly to a medical assistant. So they can print them, they can have them pre-printed in the exam rooms, or they can ask the questions directly. We left all those options on the table for the MAs to make it easy for them. If the form, of course, scores down on the bottom right, you can see the interpretation. I answered this questionnaire rather high, so you can see that then it prompts the staff to ask if they'd like to visit with a health coach or a behavioral health consultant. This is what the DAST looks like for drug use, further questions about screening. Barriers and bumps that we came across. There was some hesitancy on the part of staff to ask personal questions. There's really variability. We found some MAs that I trained, some had said, hey, you know, my family has been affected by substance use disorder. I think it's time that we ask about this in primary health care. So I'm really excited about this. We've had some who had some uneasiness about asking the questions. We've had patients show some unease with answering some of these personal questions. We've had some issues with behavioral health consultant staffing to be able to address some of the positive screeners or when a question comes up. Time is always an issue. Anybody who's implemented things like this understands that that time comes at a premium. We found that the staff so far, where the teams where we have implemented it, they've said that it doesn't seem to take up much more time, and that the benefits they find are outweighing the time that's taken up. Some of the barriers we come across is new workflow fatigue. We're implementing lots of testing. We have lots of PDSAs and tests going on. We also had to learn the billing codes for SBIRT that our behavioral health consultants can use. So if anybody has questions on those, we'd be happy to answer afterwards. So thus far, we've implemented with several teams across our 2 sites. We're testing it and tracking it, asking for follow-up. Seems to be going pretty well. MAs, medical providers, have had a lot of conversations they would not have otherwise had we not been doing this. Our next steps are to spread to additional providers, and the way we're going to do it is we're going to have our quality improvement staff go to each team one-on-one and teach them what SBIRT is, how it works, teach some motivational interviewing techniques that the medical provider can use, address some of the concerns the MAs might have. Here's what your peers have told us have helped them. And we're going to continue with some brief action planning training. We've had a couple of our staff members have completed the train the trainer course, and so they'll be implementing some of that training in the near future as well. And we continue with behavioral health consultant recruitment. And so I wanted to open it up and ask for what questions you guys might have for us, or what other things you might have learned as you implemented a project like this. Yes?
Well, first I want to make a comment. This is some of the most beneficial and meaningful time I've ever spent in the whole Person Care Collaborative. And that's not to take away from anything else. But knowing what other people are doing and how we can do something better, to me, that's the whole purpose for this. So thank you for your presentation. Do you guys have a patient portal? And is this something that could be asked prior to the patient coming in so that you don't have to use those few minutes?
The minutes and the interaction. There was a study published recently that compared the question, the answers to questions, they were these screening questions, if they were administered electronically at home versus in person at the clinic, and the rates of screening went up higher. So yeah, that's something we've definitely looked into and we're looking at. The way that our portal feeds into our electronic medical record doesn't, it would pull it in as a PDF, as a file, an image. It doesn't discretely store the data for next time to show what their answers were. It wouldn't score it automatically. So there's some issues and some gaps. And so, yeah, we're definitely looking into some of that technology. Is that something you guys do?
No. Again, I want to know who's doing something better than you are, so.
Yeah.
But I'd like to be able to.
That's our 2.0 is on our work plan for 2.0 of Esprit after because we're still in the process of spreading this. And to your point, that's exactly what I told them when they came to us. We need to have this sort of dialogue. And so I put myself out there. This isn't easy for me. It's not comfortable for me. But I wanted to share it. And I was going to say at the very end that I would like to invite other people to do the same thing. I'm sure Wendy would love to, if she's nodding here, she would love to be able to accommodate some of these sharing. And I think it's some of the best things that we can do. Are there other questions or comments, suggestions?
This is Dr. Guffey from Lake Chelan. Can you hear me?
Yeah.
Okay, great. So I'd like to echo those comments too. I found like this was a very helpful presentation, and I do hope we continue to have more of these. We're trying to get our team-based care up and running, and we're just at the nascent stages of behavioral health integration as well. And so we're trying to implement things like this, but your bumps and roadblocks slide was very reminds me of what we're having trouble with. We're getting huge pushback from our MAs and the MDs, and they're not wanting to augment their workflow, and they feel like it's too much. We keep asking them to do too much. And the other problem is, as a rural health clinic, we're having trouble figuring out how to bill for these experts. So if you could maybe take some time to say how you get people on board when they're staunchly in the no column, and then how you bill for it.
So the way we approach that, we're no different than you. Everybody runs into that new workflow fatigue. A couple things that help. We have a medical provider champion. In this case, it was me. It was developed by me. It came from me. I researched the evidence, and I got providers on board from the very early stages. This has been a 6-9 month process just for us to start testing with PDSA cycles on a couple teams. And so as we've gone, I've let the medical providers know during our bi-monthly clinical affairs meetings, this is a project I'm working on. This is the evidence behind it. And so they've been on board little by little. I think that's something that helps. Two, we started small. As we started with just a single care team. We trained them on how to do the workflow and got their feedback. We got it up and running. We discovered all sorts of issues with a patient getting mad and becoming rather upset. And so we implemented those the questions to ask permission, and it calmed it down. So we worked out a lot of the kinks on a couple of individual teams. And then when we went to say, okay, we've established it here, let's try somebody else. We had that staff who was already involved with it and was able to say, yeah, this wasn't that hard. This didn't take that long. And the medical provider to say, you know, it didn't affect me too much. A lot of the screenings were actually negative. I will say we had, I had a concern initially that with the status of recreational marijuana in the state of Washington, that we would just be overwhelmed with all sorts of positive screeners. And what I came away with actually after using it myself was that it helped me actually filter out, because as you go through that DAST and go through that audit, it filters out and just looks for people with risky behaviors, and that's who I want to identify. And so a lot of the people who do use regularly, they didn't test positively on the DAST screener because they're not having troubles at work. They're getting their stuff done at home. They're not going out of their way and doing dangerous things to be able to obtain whatever the substance might be. And so it actually helped. It helped me be able to filter through and identify folks where I can spend time to discuss the risky use. Anyway, so having the champions at each level, the medical provider level and the MA level, I think is really helpful. And they're the ones that are helping spread it to the next team. I've already turned it over to them, and they're the ones spreading it onto the next group. And we're just going little by little. And so as we come across bumps and hiccups, they let us know. And people are able to say, hey, you know, it doesn't take that much time. It's not that big a deal.
Alan,
Yeah.
I would like to just say one more thing about the work that Alan's doing. None of this work goes quickly. When I think back to when we really started doing team-based care, we started that in 2011, and it's 2019. It required a vision change in our organization. So the vision of Moses Lake Community Health is to continuously transform. And we read that to our staff, and it hurts every time you read it because it means it's a constant change. And what our staff wants to hear is, when's the change going to be over? When are we going to take a break? So I think that's foundational for staff to understand that we're in a constant improvement process. And then the other thing that probably has been as successful is that Alan meets with the provider teams individually. Is it twice a year?
Yeah.
So each provider and their receptionist and their medical assistants and their nurse meets with Alan twice a year, and they just get to talk about what's working and what's not. So it's helping reinforce that they have some input into what we're putting forth. And I think as these new things come up, it's helping them know that they have a voice. So that's just another helpful hint as you're starting in on this team-based care work to consider.
Sheila, the one thing you might want to consider, I said the one thing you might want to consider was it Matt? Matt, the 42 CFR is contingent on licensure and things like that, though. So if your behavioral health consultant is putting themselves out there as a provider, then you may be running into privacy issues.
Yeah,
with the coordination back to the provider.
Yes, that was good learning from the earlier segment.
Well, because we're
Yeah.
substance use,
You're very
that law, I know that law because I have to.
Yep.
But that's where you may want to get feedback on, because once they put themselves out there as a provider and you receive federal funding, communicating back to the doctor that's not.
So as we've had some consultants come work with us on the MAT, and they've said that if you're putting yourself out there as providing primary care, and you have behavioral health consultants who are helping provide the primary care, and substance use might be part of that, and there's diagnoses, I might be addressing it, others might.
And I don't know, I'm not well versed on what your consultants do or what they're providing.
No, it's some tricky area in here. Yeah.
Just think about it.
So we have separate specialty, if you will, behavioral health, and we're formalizing a substance use program. But how I see this working and what we do, we also have primary care with behavioral health consultants embedded, integrated, whatever I word you want to use. And that's just part of primary care. So if these issues come up in that setting, then I think we're okay. It's when they identify something and, okay, now you gotta go talk to these guys. Okay, now, but you already know that they're at risk. So you can use at least that. I mean, maybe you don't need to know the 3 chemicals they're using, but at least you know there's an issue.
And to speak to the other question, the person on the phone had asked about the billing codes. You have to be certified. So there's some certification that has to be obtained by the behavioral health consultants to be able to use the SBIRT codes. They have to have gone through a certain training. People are nodding here, they know what I'm talking about. And so if we referred them to our integrated behavioral health consultant and they're doing a warm handoff visit to address some of the issues, they can use those codes. And so it's not something that the primary care providers are using. In FQHC, there's other rules that go along with it. So we didn't even bother with it with the medical providers. And then I will say with the implementation and that change fatigue, what helps is also intermittently having some slam dunks that you implement. So things that are easy that people go, oh, thank you very much. Thank you for your time. Sorry, we went over.
Okay, thank you. There were a couple comments, so let me just make sure I get them. Go ahead. Find the checkbox. Well, my computer will work. Kathy Rhyme said, great presentation. It was really helpful to hear how you thought about how you would brought staff and patients along and what you were learning. It's an excellent example of the WPCC concept of all teach, all learn. Thanks for getting out of your comfort zone to share helpful information. And Megan said, can you send out a list of codes you're using for billing and what EMR you're using? You can send that to me, I can distribute if that's possible.
Yeah, and again, those codes they're billed by the VHC instead of using their typical psychotherapy codes. There's a separate set that if they are focusing on some form of SBIRT, so I can send those over. Yeah.
Right. Thanks, Alan. And I will put the challenge out. It was something that I was considering. It's why we put a standing agenda item for WPCC peer sharing, because it was something I was considering. And then when we did the survey, it was what you guys overwhelmingly want, which means you got to be willing to step out and share, because it's not me, it's the peer sharing. So I have a couple ideas and I'll be reaching out to some based on site visits of what we're learning. But if you have something going on within your organization that you think would be beneficial to others, bring it to the table. Let's get you on the agenda to share. You can choose how much time you want, up to about probably 15 minutes. If you say, I just want to share for 5, I can go for that too. But this is how we learn from each other. I will say that there are about 4 organizations who chose the SBIRT in their change plan. So I'm not sure off the top of the head who those 4 are, but Caroline reminded me of that. Any other questions, comments?
So Wendy, I think Megan wanted to know what EMR Moses Lake uses. Is that Centricity?
Centricity, yes.
Okay.
Okay. TCDI update. Again, this is another part of the agenda where we're trying to tie in what's going on in the other work groups. So once a quarter, you would hear from John about the TCDI work. And I do think he has some conversations he's going to have regarding TC on that part of his update.
Yeah, so I'll go through some of this quick and just give you guys kind of an update of where we are and catch up a little bit. But as you guys know, our TCDI work group has really been focused on transitions and diversion, engaging our acute care providers. So we developed 3 main aims for our work group in our meetings that we share at every meeting, really focused on, transitional care services to reduce hospital utilization, promoting appropriate use of the ED, and getting the patient to the right place. Our 2 main partners, one are hospital partners, and we cover 2C and 2D, obviously. So 2C, we're focused on transitional care programs, and we are rolling out a transitional care management program across the region. And then 2D, we really are focused on emergency department diversion, and that's predominantly focused on enhancing ER's abilities to promote ERs for emergencies and best practice. We are also working with our EMS professionals, so our ambulance companies, and they are really focused on components of mobile integrated health for community care medicine. Really looking at improving documentation, improving non-emergent transport to alternative destinations, primarily Parkside, obviously, in our region, and creating better referral systems for those patients that call 911 and do not get transported. I'm not really going to cover EMS a lot today, but I did give you a 2-page attachment in your packet that gives you kind of an introductory report of our EMS providers and what they're working on. So you can read through that to get a little better of an idea. This, though I guess the color here lighter, is kind of just a quick landscape of what we're all working on. So we meet every other month. The first part of this year, we did transitional care management training utilizing the approach that Confluence Health has, and we sent everyone out to their call center. And then we're also doing follow-up training for billing. We've been working with Collective Medical Technology to really help the ED partners get a better understanding of how they can use the EDDI system in their workflow. We are doing quality improvement training with our acute care providers right now. And then a big portion of what we're looking at doing specifically around transitional care management for the second half of this year is looking at how we can align who completes transitional care follow-up phone calls and how we can better enhance that connection to outpatient providers. And so that's really, when you think about how the WPCC partners intersect, this is a really big portion of it. And I would say we spent really the first half of this year getting more of our acute care providers processes in-house in place, and this is really where we're looking at making those connections across. So this just gives you a few quick things of kind of what we've accomplished this year. We've done the TCM training, Collective Medical Technology has been working with partners. Partners have really started 2 rounds of reporting, and just like you guys, it's been kind of that same internal QI process of figuring out your reporting, figuring out your data metrics, cleaning up the reporting, cleaning up the data metrics so we can start to see how we're doing. We actually have a TCDI page on healthcarecommunities.org page, as you guys are all familiar with this as well. Our acute care providers are also posting shared learnings in there. Any webinar we do with Collective Medical Technology on EDDI is on there. Any quality improvement training webinars are posted on here. And we are actually asking partners to submit quarterly reports. They are not as intense or heavy as your guys' quarterly reports, so they're submitting them via Excel in that, but they are all being posted on here. I know I've been working closely with Wendy, so if she feels like there's any relevant, pertinent information for you guys, that she's going to make sure that gets pulled over and shared. We're still a little hesitant to open it up bigger than the TCDI community because, again, they're posting their personal reports, organization reports on there, and they've been willing to share that amongst our community, but broader, we haven't really discussed that. Whoops, other direction. So again, really our next step is figuring out how to better coordinate this transitional care calls, follow-up process across the region. So we've been looking at, and we started initial discussions about working with partners in specific regions. So breaking it up in those natural Chelan, Douglas, Grant, Okanagan regions, and working with the partners in there to determine how we can best coordinate care from acute to outpatient setting. I'm really looking at how we can create workflows and processes in the following ways. So identifying the organization most appropriate to provide a follow-up call. And I can say right now, we still have issues, even within the medical community, when a person gets discharged from the hospital, they're still receiving multiple calls at times. Even though we're all best intentioned, it happens. And I think I've said once, that's a good-ish problem to have, because at least people are following up. And then notifying organizations when their patients are discharged from the hospital. I would say, as we start these discussions, it's really going to require both frontline and leadership in this, because frontline really knows what to do. They understand the processes. But a lot of follow-up calls have been developed in these processes have been developed really because of organizational decision as well. Whether it's they feel it's the best thing for the patient, or they have a financial risk on that patient, and they want to make sure that they're getting good quality care because they're financially at risk if they don't. So the two extremes of the issues that we've really seen throughout this problem is really obviously issue one. So you have a patient discharged from the hospital going to the medical clinic, but then they have multiple people calling. So the hospital might have a transitional care nurse following up with them. Their clinic might be calling them, so they might have a care coordinator or a transitional nurse in the clinic following up with them. We're not even getting to the third example where there's community-based organizations also following up with them as well. And so there's some people who get, you know, all the care in the world and follow up with 5+ people, which is great, except that it's frustrating because they receive this call 5 times in 2 days and then they don't know which person to call, right? They might receive different directions. Then on occasion, you also have a person who gets discharged from a hospital and maybe they don't have a PCP or they're not established with a PCP and they don't get followed up on. So obviously what happens, they don't know what to do, they don't have an appointment scheduled, and they end up back in the hospital because they didn't know how to take their medication or they just didn't really know how to make that connection. So again, you go to that other extreme of obviously people who get, you know, lost in the system and don't get that follow-up. So I think we all know why coordinating this is important. We want to ensure the patient is followed up with the most appropriate organization. And so there's going to be instances sometimes where it might be good for the hospital to do it because they don't have a PCP. There might be instances where it's more important for that PCP's office if they have care coordination established or transitional care processes established for them to do that follow-up. It's going to decrease the number of phone calls for that patient, and so they'll know what orders to take. And again, make sure that they connect with their outpatient clinic and receive that appropriate follow-up care. And for organizations, you know, obviously it's better outcomes for your organization's patient. That's the key focus. But it's also going to reduce duplicity and decrease cost and improve coordination and efficiency. So we're really, this is a slide, we showed this back in December on the different ways that we can partner with you. We're really focused on bullet number 2 at this point, aligning all calls and rate between agencies in the region to reduce duplicity of work. So we're really moving into that process. Like I said, we have a lot of our general work established, but now we really want to look at that coordination across agencies, that true emphasis on how transitional care works. It doesn't happen by one agency talking to itself. And we're looking at doing it in kind of a smaller region-specific model so that we can start testing specific sites and their patients and how they connect acute care with outpatient care. And that primarily, I will say that in transitional care management, it's focused with primary care clinics, not behavioral health. But as we go through this process, we would be interested in hearing from the behavioral health providers as well and how they see they fit their role into this. This is all at the beginning stages, so don't assume that we're coming up with this great plan and then asking you guys to be part of it. We're going to be asking for input from you guys on the process. If you ever want to join us, meetings are open. Our next one is Thursday, July 25th, 10 a.m. to 11:30 a.m. at the Chelan Douglas Health District. We've kind of ventured a little bit more to promoting kind of a video conferencing meeting, just because our partners are all pretty spread out. And so, you know, feel free to join by video conference, feel free to come in person. It's kind of up to you what you would like to do, but you're always welcome to join, you're always welcome to listen in and hear what we're talking about. Any questions? You guys are too easy. All right, thank you guys.
So I'll say that as John was talking about having these smaller regional meetings, you'll see us reaching out to you. As an example, we'd say we have Samaritan Hospital for this Moses Lake area. We reach out to Moses Lake Community Health, Samaritan, Columbia Basin Family Medicine, Confluence within this area. to all come together and talk about how we're going to do it. And Grant integrated. I didn't mean to leave you out. We'll definitely invite you to the table. How are we, and Parkview. Sorry, I'm going to miss someone, and I'm sorry. But how do we all come together so that we'll say, so Samaritan's not trying to navigate 5 systems, and you guys are all kind of on a similar, you're going to have to personalize a little bit for your individual clinic, but how can we develop some similar workflows that will also help the patient? This would be more of a patient-centered approach. Trying to move towards. Any questions? Okay, I'm going to turn it over to Kathy and Tina. And just to preface this, when you go into your measure data reporting on the portal, you will now, as of today, start to see some run charts based on the data that's been entered both in the Q4 2018 and Q1 2019. And Kathy and Tina are going to be talking about that.
Thank you, Wendy. And unfortunately, Tina is not able to join us, so it will just be me, but I will do my best. If you can hit the next slide, please. So the purpose of this next few minutes is really to show you what the dashboard looks like, try to help increase awareness of the data that we're currently collecting, just to get you starting to think about it. And most importantly, to really speak to what your role is now as the WPCC leadership. What are the things that you can do now to help your staff as we roll out this data? So the next slide, please. Next slide, please. Thank you. So this is just a screenshot of the Healthcare Communities page. You're going to see, as Wendy mentioned, unveiled today is the WPCC measures. You will now be able to see performance on your quantitative measures. I know many of you in the room have experienced going to the page and entering data for the numerator and denominator, and now you're going to be able to see what that looks like. 2 ways to access that. One is by the left-hand navigation with the arrows pointing to it. There's also a link, change plan links. You can also click on the WPC measured data. And there are guidance and screenshots. It's pretty intuitive, but there are guidance and screenshots in the FAQ right below that change plan links. Next slide, please. So when we look at this next slide, when you click on the measures, this is what you'll see. And you'll be able to see that there are a variety of different things that you can look at. And I ask you to put your attention to the center where that oval is. And you'll see first there's a drop-down menu for topic. And that drops down to any of the 8 topics that we're currently working on. So you could click that and look at chronic disease management, behavioral health integration. Right now we're looking at access. And then the other option that you have is to look across all organizations, or you can search for any organization, including your own. And they're all listed in the drop-down. And then when you click on those, you just give the page a moment to refresh, and you'll be able to see very specifically whichever topic you'd like to see and whether you'd like to see one organization or multiple organizations. And what you'll see here in the dashboard are these graphs. And in quality improvement, many of you know now these are called run charts. So the next slide, I just want to talk briefly about why run charts are chosen. And it really has to do with measuring your data over a period of time. So we're thinking about the fact that all of you have change plans. You're doing a lot of work in your own organization trying to improve things. So we want to be able to look at whatever system that you want to evaluate. What's that performance over time? And so this really allows us, looking at the data in this way, allows us to see that all the work that we're doing is resulting in improvement. And I call your attention just to the graph on the slide here. This is from a project that I did with IHI a couple of years ago. And this particular team was trying to decrease their cycle time. Cycle time is defined as toes in to toes out of a clinic. And so some people find that they get backed up and their appointments are backed up, or people come and wait and they're in the clinic for hours, and it causes one of the big causes of distress for patients who end up spending more time than they wish at your clinic. So this particular team, you see that they start and you can see that there was a lot of variation from anywhere from 60 minutes all the way up to 98 minutes, and then back down. And if you had looked at any two consecutive points, you might say, wow, you know, our cycle time is it's getting longer and longer initially, and then, wow, it looks really great now. We've really decreased our cycle time. Our patients aren't waiting in the clinic. And when you look at it over time, you see that there's just a lot of variation in that data. And so we can tell that over a period of time, we shouldn't act on just one point or the next point, but we really want to get a big picture of what is our actual cycle time, what does it look like at our clinic overall, and then are the things that we're doing making a difference. And so if you look at the last 6 points there, they're the ones that are in a different color, they're kind of gold color. Those are the points that tell us that in fact, we are having a difference over time. And that is because once we got our system where we could measure the median, which was our baseline, we can really see that those last 6 points, those last 6 months show us values that are less than where we started. Now we know that all of our efforts are paying off and we've actually decreased that cycle time. How we get to these is called run chart rules, and that's not important. But what's important is that over time, you're going to be able to look at the measures you submit in a run chart format. And over time, we're really going to be able to see the impact that you've had with the changes that you're making. And I'll add that these run chart rules are like statistics. For those of you who love statistics, these run chart rules are actually statistically significant. So we can legitimately say, yes, this team made a great impact on their cycle time. So again, the message here is run charts. We're going to be able to teach you more about run charts and how to interpret them once we have additional data. But let's move on and just look at the next slide. I just wanted to show you a couple of things. So first, you're going to see that this is behavioral health integration. And I call your attention to a couple of things on the screen. First of all, there are some charts that have no data points. That's because no one is currently measuring those particular measures. In some, you can see that people may not have reported in the last quarter of 2018, but they are reporting now. So that's perhaps the plan I'll call readmissions chart. And then for some, like the depression screen and follow-up, you see that there's a number there for the 2018 Q4, and there's also a number there for what's hidden, the 2019 Q1. The other thing that I just want to show you is when you hover over one of those numbers, you will actually see, in this case I hovered over the 53 on the depression screen and follow-up graph. The other thing that you're going to be able to see is that the value, the percentage is 53, and it's based on the numerator of almost 74,000 people out of a denominator of 138,000 people. So that gives you an idea of how that number was calculated and how many people that actually represents. So that's a great, this is one of our most popular measures. And you can see that at the time the screenshot was taken, there were 12 organizations that were reporting that measure. So just to give you an idea of the type of data that you'll be able to get here moving forward. Right now, as you can see, we've got some blank spaces. We're early in the process, but pretty soon we're going to have additional measures that you're going to be able to follow over time. So quickly on the next slide, I just wanted to say that just as you're looking at these graphs, remember, all of you know this, that the data is self-reported. We're not auditing it. It's quarterly over time. Also, as I mentioned, you can click on any organization that you would like to see. So if you know that another organization is looking at the same metric that you are, and you want to compare performance, we agreed that data would be transparent, and you can do that. We also know that the data that we see is only as good as the data that goes in. So one of the things we need your help with is to make sure that the data going in is the best that it can be. We also know that there's only a few measures that are reported widely, and we're hoping as we move forward that more people will be using the same measure so that we can get a better overall impact of the cohort. And as I mentioned, you can look across the topic area or by organizations any way you would like. The next slide, and it's only just quickly to say that we have just a few measures that are being reported widely. The depression screen and follow-up is our most popular measure. And you can see the numbers go down pretty quickly after that. So the number of organizations on that chart, 2018 to 2019. We do know that many organizations are struggling to report measures at all. And so this is really the crux of what I have to say to you in the next slide. We really need your help. So right now we have just a couple of weeks before the next reporting time. We heard from Wendy earlier that the next reports are due at the end of June. So along with Heather and Mariah and the team, you as leaders can really help work with your team to make sure that you have the right measures, what's going to be meaningful for you. Do we really need all the measures we have? You see that many people have over 30 measures. Do we really need all of those? Maybe we do, maybe we don't. Are you having trouble getting the data? Sometimes leaders need to intervene or prioritize data in their IT infrastructures, because IT usually has a lot going on. Once you get your data, is it real? So teams will, all the time they'll come back and they'll say, well, I know we measure blood pressure on everybody and our data says that we only measure in 60%. What's that about? Well, there's a reason for that. It's usually not entered in the right field, or people enter it in different fields. So there's reasons why the data doesn't reflect what you think it should, but this is a great time to sort those things out. So is your data, does it look real to you? And then just begin to think about, visualize having data over time for measures that are important, and begin to have those conversations with your team. How can we use this information? This isn't just for WPCC. This is for your organization as well, to learn how can you take the things that you're learning, how can you make things better in your organization. And this data, monitoring data over time, will really help you improve over time. So on the next slide are just some of the things that are going on, and I know Wendy mentioned a couple of these. If you can click to the next slide, thank you. We know that the coaches are working, really thinking about, are these the right measures? Do we have them specified? We also will be able to help with data collection, trying to figure out how to make things easier for you. And then lastly, I wanted to mention that we do have an upcoming webinar. We're going to hold the QI Affinity Group June 25th from 1 to 2, and that particular meeting is totally dedicated to the dashboard. Data, what does it mean, measures, and you are welcome to bring any of your questions, comments, any concerns that you have to that meeting, and we're hoping to share across organizations to talk about their experience. I think I'm about a minute over, sorry Wendy. But I'm happy to take questions or comments offline. So thanks, Wendy, back to you.
Thank you. I know we're right at time, but does anyone have a quick question they want to ask while we're here? Okay. Thanks everyone for your attendance. Colleen, I do want to say one thing before Dr. Coldy jumps offline. I didn't get permission to say this, so if I'm in trouble, it wouldn't be the first time. Dr. Coldy is moving on and Craig Mott is taking his place, but I wanted to publicly say thank you to Dr. Coldy. He's been at the table since I've been here, but I think he started coming around, I think in spring last year, and he's added a really valuable voice to this table. And I know our team has truly appreciated his input, and I'm sure you have as well. So thank you, Dr. Coldy, and if you get a chance, drop him a note and wish him well as he moves on to his next adventure. My next thing I wanted to say is Pathways Hub will be moving and expanding to primary care in the Grant County, except for Cooley Medical Center. It's probably the easiest way. Cooley Medical Center will be in the next cohort because they're more linked with more northern part. So you'll be hearing from me more on that, or Mariah and Heather. So without further ado, thanks again for your attendance and participation.